Ladies and gentlemen, good morning. I'm honored to have the opportunity to share my personal experience in past 20 years for clinical research and hospital care and dialysis experience in Taiwan. So, and we know there are many patients more and more in the world. So I know the cardiologist, the oncologist would like to control the cancer. But we know if the patient gets cancer, maybe from the early stage, they would like to receive radiotherapy, chemotherapy, and radiotherapy or psychotherapy. And new advanced treatment include of immunotherapy or target therapy and the other preceding treatment. So maybe the patients cannot control the cancer until the cancer stage maybe become to distant, meta to the other system. So we come to an advanced stage. So we know from the early stage, the health provider will give the patient anti-cancer treatment. But when the cancer is incurable, and they will provide supportive care or private care, hospice care. So we know if the patient enter to the advanced stage, the private care and the anti-cancer care maybe combined with to give the patients. So we know the cancer care continuum from the screening, diagnosis, treatment, and until to end of life. We know we care the patient is a whole person. The person will be live in under different social cultural environments. So the patient needs is very complex. So we know the patients maybe their care needs was affected by internal environment and the external environment. So in nursing science, we would like to take care of the patients. We provide total care for total suffering. So the support care needs the include of emotion needs or psychosocial spiritual needs. So I think we have to respect the patients' any individual and holistic and unique needs. So I think when the cancer patient they receive the anti-treatment, when they are incurable, maybe they or critical status, they will be sent to ICU units. Where is the patient? You know, India. So the patient around the many machine and ventilator or some machine. So I think which is the most important, survival or quality life. So I think the medical staff needs to be culture ethical reflection competence. So we know each cancer oncologist would like to generate a new drug. So but we know the new drug have to be approved by many clinical trials. So if there are more than 10,000 new drugs, we know they have to be passed through phase 1, phase 2, phase 4, 3 trial study. So we know there are many potential new drugs, but finally phase 6 or 7 years, only one pass through FDA. So you know the cancer patients, especially terminal stage, they have the opportunity to receive the clinical trial. But we know there are many clinical trials gradually moved from to Asia, from Europe to Asia. We know in Taiwan is also the leading country in Asia. the phase 3 and the phase 4/3 growing quickly. So we find that there are more than 100 RCT randomized clinical trial for the cancer patients. Just for the management of pain, include acupuncture, relaxation, tai chi, and yoga, the complementary therapy. So I think there are many clinical trials in oncology world. So the patient enter to the terminal stage. They have the opportunity to receive the clinical trial. The clinical trial, that means is the scientific knowledge, and so the research is well organized, it is well designed. But the clinical means is the physician have to go to the bed to visit the patients. So I think the good clinical medicine, I think requires to marry with combined with scientific knowledge and clinical care. So we know the workflow of clinical research, maybe from the preparation, conducting, and the post-marketing. So the clinical trial, when the clinical research nurse conduct the clinical trial, I think the patient safety and the integrity of data is very, very important. So the informed consent is a very, very important issue in the during the cancer patient in terminal stage. So ethical issues of informed consent in cancer clinical trial. We know we have to provide adequate information to enable patients to make a decision. But we know there are many medical staff able to provide the information to the patients. Because we know informed consent. Informed consent means we provide the information and then the patient's understanding and the patient make decision making. But we know the informed would like to disclose the information by the research team or by clinical medical staff. So I think what is the truth? Include of the patient's diagnosis, patient's terminal stage, and include of clinical trial, bad or benefit. So I think it has to be give the well information. The patient receive the information and understanding, and then they consent. So I think we have to provide the informed consent. We have to respect the patient's autonomy and the decision making. So we conduct a research. We use a semi-structured interview guide to interview 10 patients, participants, and 10 clinical research nurses to communicate with them about the informed consent experience. We find that communication in higher pressure situation that face the pressure of disease progression and too much trial information and unequal power relationship, because the oncologist always pursue the encourage the patients to involve to enter to the clinical trial. So this situation makes patients tend to trust their physician's recommendations. This is one patient. He said, "My physician told me that my cancer was growing and affect me with this option. I only asked one question: would this drug kill me? My kids are still young, so it's a hope for me to survive." So the patients would like to receive the clinical trial. From the clinical research nurse, when they give the information, and he find that wrong expectation from the trial participant, and the participant confident with the physician. The clinical research say the PI may think, why you spend so much time in informed consent? So she say you could go to visit many research participants. So this is credit for the PI. So it's very difficult. This ethical dilemma is also also from the clinical researchers. She say some people may think they are so lucky to enroll a trial. Even though I try to clarify their misunderstanding, but they still have a positive belief in the trial. So as in the clinical preference, people with a life-threatening illness, they maybe influence participants in a trial because they see it as their only hope. So the information and the understanding maybe is not enough. It's not enough. So they cannot make true decision making. So the factor of influence autonomy decision making by patient in cancer clinical trial. We survey 120 patients with cancer. And then the majority of participants report they make a decision of trial by themselves. But they say they read the informed consent. But we find that the patient maybe regret. We find that the predictor of understanding of cancer clinical trial include of educational level and understanding informed consent. And the predictor of decision regret, maybe there are 4 predictors for the advanced cancer patients. So we know if the patients cannot to recover health, there are many total suffering. So we provide the palliative care to increase quality to get the good days. So from curative treatment till to palliative care, I think clinical trial or palliative care treatment, which is appropriate for the patients. I think this is why the palliative care for the advanced patients is very important. So how to provide the most appropriate care for the terminal patients? I think maybe when we start the life support, we keep the patient. This is another ethical dilemma for the medical staff. Are we keeping the patients or allowing dying or letting to die? I think it's very important. Have to be reflection in clinical practice. So it's not killing. We say for the palliative care philosophy, it's allowing dying and it's letting die. So the patient from the diagnosis, they receive anti-cancer treatment, and they decrease the quality of life till to death. But the euthanasia is to short of life, but palliative care not short of life and not prolong the death. The palliative care just provide the total care increase of life till the natural death, and don't delay the death survival. Okay. So finally, I think the time is very limited. So palliative care for all. So we say we have to face the ethical dilemma in the clinical practical. When the disease treatment is not cannot cure the patients. The advanced cancer patients would like to choose clinical trial or palliative care. I think we have to respect the patient choice. So finally, I think we provide well information treatment for clinical trial or palliative care knowledge. And we let the patient to choose by themselves and use the shared decision-making concept to help the patient to make decision by themselves. So we would like to let the advanced patient or terminal patients, if they have the opportunity to receive the clinical trial, we have to provide the clinical trial information to the patients. And if the clinical trial is not appropriate for the terminal patients, we have to provide practical information for the patient to pursue good death. So I think this different treatment is all is very important for the terminal patients. Okay, thank you, and
thank you, Professor Hu. The next speaker is Dr. Lee Chen.